The traditional model of coagulation, called the cascade model, conceived of clotting as a series of steps. One protein reaction activates another. The cascade follows the intrinsic or extrinsic routes that converge into a common thrombin-mediated pathway. While the cascade theory provided a useful model in vitro, it did not provide an adequate explanation of hemostasis in the clinical setting. Recent clinical data suggest that properties of cells have a role in controlling coagulation. The surface of activated platelets appears to be an important site for the thrombin generation necessary for clot formation. In this cell-based model of coagulation, there are three overlapping phases. The first phase, initiation, takes place on the tissue factor-bearing cell. An injury to the vessel wall exposes tissue factor, which has a high affinity for factor 7A. Factor 7A binds with tissue factor to form a complex that converts factor 10 to factor 10A. While this may not be sufficient to sustain hemostasis, this small amount of thrombin can initiate coagulation. In the second phase, amplification, thrombin moves to the platelet surface, activating the platelets as well as factor 10 and promoting aggregation of platelets at the site of injury. The coagulation response is amplified as platelets adhere, become activated, and accumulate activated cofactors on their surfaces. In the third phase, propagation, active proteases interact with their cofactors on the platelet surface. Activation of factor 10 produces a burst of thrombin, a critical step in the clotting process. Thrombin converts soluble fibrinogen into an insoluble fibrin clot. This thrombin burst promotes the creation of a stabilized solid fibrin plug. This cell-based model of coagulation not only explains normal hemostasis, it also explains the mechanism underlying hemophilia. Individuals with hemophilia A or B are deficient in factors 8 and 9 respectively. For this reason, patients with hemophilia cannot generate thrombin in sufficient amounts to induce normal clotting. Replacement therapy with factors 8 or 9 can normalize coagulation. However, if hemophilia patients develop inhibitors against factor 8 or factor 9, replacement therapy does not lead to normal coagulation. During a hemorrhage, factor 7A binds with tissue factor to form a complex. The complex converts factor 10 to factor 10A, leading to the production of small amounts of thrombin. However, due to deficiencies in factor 8 or factor 9 in hemophilia, factor 10A is not generated where it can be incorporated into the prothrombinase complexes on the platelet surface. The deficiency of platelet surface factor 10A may lead to inadequate thrombin generation, preventing the creation of a stable fibrin clot. Recombinant coagulation factor 7A, marketed as Novo-7, is a novel hemostatic agent used to treat bleeding episodes. Novo-7 induces hemostasis by two interdependent mechanisms, by binding with tissue factor and by directly binding to activated platelets. During an injury, tissue factor released into the bloodstream forms complexes with Novo-7 on tissue factor-bearing cells. These complexes activate factor 10. Factor 10A produces small amounts of thrombin. This thrombin may contribute to coagulation, although the presence of tissue factor may not be necessary for Novo-7 to induce hemostasis. Recent evidence suggests that another pathway, the direct effect by Novo-7 on activated platelets, may be an important mechanism of action. During a bleed, platelets become activated and begin to adhere to the site of injury. Novo-7 binds directly to activated platelets, promoting the generation of factor 10A on the platelet surface. This leads to a burst of thrombin that promotes the formation of a stable fibrin clot. Activation of factor 10 may continue for an extended period. Its location on the activated platelet surface allows it to be directly incorporated into the prothrombinase complex. This process can occur even in the presence of inhibitors. Because Novo-7 cannot bind to unactivated platelets, procoagulant activity is restricted to the site of injury. Theoretically, this could explain the low prevalence of systemic thrombosis. Through describing the role of platelets in clotting, the new cell-based model has provided new insight into the physiology of coagulation. The new model also helps to explain the efficacy and safety of Novo-7 in inducing hemostasis.